Sometimes when patients present with cognitive complaints, it's not always clear what the etiology might be, for which you will prescribe a variety of different treatments. The use of electrophysiology can be an adjunct help in identifying not only the correlation to the symptoms from the functional impairments in the brain, but can guide different diagnoses and guide different treatment decisions. So, the first patient is a 56-year-old male, and let's do an EEG. So we use a 19-channel standard 1020 international system of sensor placement, record a 19-channel EEG. We can also pull 3-lead ECG to calculate heart rate variability, and with the presentation of some stimuli, also obtain some event-related potentials, or ERPs, to help take a look at processing speed and network activity. So we're going to look at 3 cases that all presented similarly for reason for the visit. Doc, I think I'm having some trouble with anxiety. My memory seems to be getting worse. I feel like I'm in a bit of a brain fog, and I'm having trouble sleeping. Now, on the surface, maybe sertraline or even trazodone to help with the sleep would make some sense for out-of-the-box care. But if you have the capability of taking a look at the brain itself, looking at the electrophysiology, you'll see different presentations and different reasons for the symptoms. And by having a better understanding of etiology, it opens up the door for different treatment options. All right, so after the EEG, routine EEG was completed, the narrative report from neurologists showed no findings, or what's often called the normal EEG, and we use normal in quotation marks because the absence of a finding is not absence of an actual problem. It's just you didn't find it with this particular test. But it's still good to run this test to look for epileptogenic morphology, which will be treated differently if we're seeing that level of dysfunction, whether it's causing spike and wave morphology or other type of events. Then that EEG is of great value because you can take that EEG and compare it to a normal reference group by age and gender. And that's what these green heads or circles are showing us. These are 19 channels represented by the small dots, and then each head each circle is a 1 frequency hertz bin. And we can see now green is normal limits, and outside of green we're looking at either too much of that frequency, which is red, so too much amplitude, or an excess amount, in this case of 4, 5, 6, 7 hertz, generated from the on the cortex. We see it midline at location FZ, and source localization using Loretta tells us it's coming from Brodmann area 32. And that 5 hertz is excessive in the primary generator is an anterior cingulate, which makes sense for the presented symptoms of brain fog, not being able to focus, can't pay attention, executive dysfunction. Makes a lot of sense. Then the second finding, is just below that. You see to the left temporal, left parietal area, an excess of 5, 6, 7 hertz. And that is sourced to Brodmann area 22, this pure temporal gyrus, and that region is in large part responsible for language processing. It's proximal to Wernicke's area. This is not inconsistent with someone who's had a head injury. So probably a coup counter coup, right frontal, left temporal parietal damage. And in fact, this person did have a bicycle accident, and that was the start of this reported symptoms of I can't concentrate, I can't focus, having trouble with sleep, I think maybe I'm depressed, I'm starting to have some anxiety about my condition and my symptoms, and that's what brought the person in to be seen. You'll also notice on the third row of heads down, 13, 14, 15 hertz is elevated. And that's compensatory for the frontal slow content, but that compensatory beta can produce some anxiety symptoms. So the reason for this person's presenting symptoms is from a head injury, and we'll proceed with treatment accordingly. In the second example, a U.S. Navy Special Operations gentleman was seen with similar symptoms. I'm having trouble focusing, hypervigilant, I have worse anxiety, having trouble sleeping, my memory's starting to fail, and this is someone with a very high intellectual functioning. That's represented also, as you can see, with a primary posterior alpha peak at 12 hertz, atypically elevated. These folks generally are wrapped a little tight, and that's a little high. I hope ideally it'd be a little bit more closer to 10, 11 hertz, but we do see good semantic memory with a fast dominant alpha frequency. But we're seeing two things here in the data. We're seeing a pattern consistent with depression. It's low alpha power in the frontal cortex, and we see that here in the blue. It's noticeable already at 7, 8, 9 hertz. That's one feature. It's secondary. The primary problem is the eyes closed alpha at about 13 hertz on average, 12, 13 hertz, and it's seen posterior with a right posterior focus. Very consistent with PTSD, and the eyes open EEG incidentally does not show this elevation in fast alpha 2 frequency at this 12, 13 hertz. And if you look at the Loretta, it'll generate the source localization, and it's part of the default mode network. The Kunis is an important part of that network. Incidentally, when the eyes are closed, there's still a lot of sensory activity, and there's not a lot of brake. All gas, no brake. That's one of the features of this condition, dysregulation and the ability to inhibit. And that default mode network is a very important piece of that capacity of the brain to put the brakes on, put it into neutral. And these two features are consistent with both combined PTSD with depression, and it's common to see those occur together. And seeing them like this is very helpful to the patient, because they can understand that they're not losing their mind, that there really is known identifiable targets for the symptoms, and that helps us guide treatment. In this case, we can treat depression with medication, but there's other ways to addressing it as well. In this case, theta burst TMS would be helpful in activating protocol. That would also help the 5 hertz that's quite deficient. The 5 hertz deficiency, seen in the upper right-hand corner in blue, will also make it difficult to sleep. I believe that the hippocampal theta is important part of the process of getting good restorative sleep. EMDR therapy is another way to try to address the PTSD finding. A third example, and one selected to help punctuate the biomarkers seen with insomnia and PTSD, is a 64-year-old female who's had chronic PTSD for many decades. She's actually a psychotherapist and has reported fatigue, brain fog, difficulty paying attention, starting to see some frontal 2 and 3 hertz developing in the frontal cortex. And certainly we see the deficit of 5 hertz again. That's very consistent with people with insomnia. And the classic elevated high alpha, and that alpha rhythm is generally about a frequency faster than the peak alpha. Hers was 11.5, and we're looking at 12, 13, again, right posterior occipital area of the brain, and that's sourced again to an area of the brain that's part of the network and default mode network. In her case, she has trouble with that resting state, being the capacity to have the brake or put it into neutral, if you will, and overactivity of sensory processing when the eyes are closed. And you'll notice when her eyes were open, everything was within normal limits. And then with the eyes closed, the sensory activity really cranks up. And that's part of that process of the amygdala and the hippocampus signaling lack of sensory input, lack of seeing who's coming, can't detect danger when one of your major senses like vision is cut off, and that we see quite an elevation then in activity, which is no surprise then when people report when they close their eyes, they feel like their brain is racing and they just can't shut it off and have trouble falling asleep. So seeing these two PTSD cases in a row, one with an ongoing more severe depression and both having trouble with insomnia, but then this older patient with insomnia and PTSD, classic PTSD pattern that she's had for many decades. And then different therapy options again. I mean, this is another case where a theta burst transcranial magnetic stimulation approach is fruitful. Again, EMDR is a fruitful approach. Other medications like prazosin can be of help to help block nightmares. And there's still a place for like SSRI, like sertraline as well. Even hydroxyzine can be of some help with insomnia. Trazodone, some people can be overly sedating, and perhaps in her case that might be so. But these open up some options, and you can quantify the results of your treatment by repeating the tests and see how much movement has the intervention delivered. Are we moving the needle in the right direction? Are we getting closer to normal? And so does the objective measures correlate with what the person is saying as far as a response to treatment? So hopefully these three very quick, very brief vignettes of looking at quantified EEG and source localization to the regions of the brain gives you a little bit of insight how this use of electrophysiology testing can be adjunct and very helpful in your practice.